So I first want to take the time to appreciate you guys for inviting me here. This is a topic that's pretty near and dear to me as far as mental health. So I'll briefly tell you a bit about our company. Insight provides the provider. So we have psychiatrists, nurse practitioners, psychologists, clinical social workers. So we go into health systems, our outpatient clinics, FQHCs, and we provide them with clinicians that they're having a hard time finding. We've been doing this 16 years. Outside of the VA, we're the largest telebehavioral health provider. Okay. Not working?
You're the first one to tap it.
I know. It may be me. Okay. So it threw me off a bit there. So hopefully today I can just kind of give you my background. I think someone said something yesterday as far as Maya Angelou, I'm not really good with quotes, but I really want to make you feel. A lot of people in the room do this on a daily basis, so I'm kind of preaching to the choir. But if I can move you to kind of keep that enthusiasm, take it back to your community, you know, it would go a long way. I think mental health has been something that's been stigmatized. We kind of like to brush it under the rug. It doesn't reimburse very well, and it's very easy to kind of skip over. So I've been doing behavioral health for the last 8 years. I was in the hospital system as a discharge planner. I was in home health care, going into people's homes, nursing homes, assisted living facilities. So I've seen it from kind of all different factions. And I'm going off the cuff, so I really want to kind of move with the slides. So I'll just go off the cuff. Anyway, so the reason why I have a passion for, here we go. Bear with me, I'm sorry. All right. Okay, so agenda, back on track. So I'll just kind of give you my personal journey and why this is so important to me. As far as communities, I'm going to kind of drill down to foster care and adoption system. I grew up in the foster care system, and so I always told myself if I ever got the platform to speak on behalf of foster youth that I always would use that platform. So I'm just going to kind of give you how telemedicine can change that particular community and, you know, speak to it on a broader range as well. Overcoming current challenges and a case study, which I actually am probably going to switch up. So my story actually starts kind of with my family's story and just kind of generations of mental illness and substance abuse. So my grandmother, who I never had the opportunity to meet, killed my grandfather, who was domestically or was abusing her. So my mom saw that at 4 years old, witnessed the entire thing. So I think that has a lot to do with where she is right now. So my mom is schizophrenic, struggled with substance abuse her entire life. So I'm obviously in the middle. My father, who I didn't have much of a relationship with, committed suicide when I was 9. So because of all this, he had substance abuse issues as well. I grew up in the foster care system. I went in at age 5 and aged out, bouncing around from Atlanta. So it was Atlanta and Florida. Foster care, I guess, you know, 20 so years ago, you would go in and out, I mean, 100 times. I mean, they did everything in their power, and I get it, to try to reunite you. Now they've changed that. You get so many chances, and then they kind of say, hey, this is not that great for the kid. So just give you kind of a snapshot of foster care. So there's more than 400,000 foster youth currently in foster care system in America, more than 100,000 waiting to be adopted. 55% will be reunited with parents. So I think this is important because we have to take care of the mental wellness of parents, kids, you know, that trauma that they go through. Most of these kids are going to go back to their families, and so we need to take care of that. Average number of placements is 3, and this will tie into kind of some points I'll make later on. In Florida, one of the things that we passed, and I actually am excited about in 2014, that they extended foster care from 18 to 21. So not only in foster care, you bounce around, you pick up different morals, values, things happen to you. At one time at 18, it was, glad you were here, nice to see you, farewell. So I think now they're realizing that at 18, that doesn't necessarily make you an adult and you need additional support. So this is where we kind of get into the mental health part of it. So 50% of foster youth are determined to have clinically significant emotional and behavioral problems. I always joke, you think, I mean, most people end up in foster care, not by the best, the best reason. So my own kind of personal way of going in, and this is why I was blessed enough to become a clinical social worker, so I was able to read about my issues and interventions and tools to kind of make myself better. But at age of 5, I remember my mom, it was me and my sister and my mom in Atlanta. She took me to General Motors, and she told me and my sister, go to the security guard tower and let them know you're looking for your father. And so we went, and they said, we don't know anybody by that name, and when we turned around, she was gone. So that's a pretty traumatic way to kind of enter into a system. Now, now when you go into the system, they try to get you as much therapy as possible. But because there's such a shortage of psychiatrists and therapists, sometimes you're waiting, or sometimes you don't get the specialist that is best meets your needs. So I think this population really kind of demonstrates the need to utilize telemedicine to extend people. You're able to see more people. Myself, I'm able to practice in the evening hours because I can be at home and I can just come downstairs versus trying to drive. So I think we really have to use telemedicine to reach these populations that are underserved. Between 1 and 3/4 children that enter the foster care system exhibit behavioral and social competency problems. So again, coming from backgrounds where you've witnessed domestic violence, drugs, neglect, trauma, sexual abuse. And when we age out, we don't fare too well. Most of the time we don't go off to college. We have no support systems. And you got a lot of emotional things that you're trying to deal with. You don't understand, where they manifest from, where they come from. So we really need to, I guess, kind of hone in on the importance of mental health. Now, I'm talking about this population, but this extends to all different types of populations. I work with cancer patients who are trying to take care of home, take care of kids, they're dying. How do you deal with that? So some of the effects, I talked about the high school rate is not that great. This is the statistic that really kind of blew my mind when I came across it. So foster kids or foster care alumni experience PTSD 5 times that of normal populations, but 2 times that of a combat veteran. That's insane. Now there's a lot going on with PTSD, a lot of resources. But I mean, to me, it still blows my mind that that is the case for foster youth. Dependency issues, drugs. So these are some of the issues from a report. And again, this is part of the broader population as well. Access to service. So that's the big issue. I mean, I think that's the most exciting thing about telemedicine is that we now can have access to the actual service. You're not limited to the practitioner that lives in your community, if you even have a practitioner that lives in your community. Budget deficits. So a lot of times, and I hear this all the time, the funding is not there, the reimbursement is not there, and people just go without. Again, this is one of those populations that is very easy to kind of look over. People don't understand it, families don't understand it. Rural areas, I think everybody gets that. I do think we need to start moving away from just thinking telemedicine is most beneficial in rural areas. I'm in Orlando. If you call to get a appointment with a child and adolescent psychiatrist, I think I called 2 months ago for a client, 28-week wait. So it's not just a rural area issue. There are not enough psychiatrists even in metropolitan areas to meet the demand. So I think, I encourage everyone in the room to let's kind of broaden that conversation. I think every time I'm speaking to someone, everyone kind of gets the rule, but they forget, we still don't have enough psychiatrists and counselors even in metropolitan areas. Collaboration, so I'm excited because you know, there's a lot of technology presented in the room, and that's one of the things that I think we really can maximize on in telemedicine as well. It allows everyone to collaborate more easily. So if I'm the clinical social worker, I may be able to have a session with the mentor, the case manager, the parent, and we don't all have to worry about transportation or being in the same site. So some of the implications is cost. So it makes sense to really hone in and take care of this population because we are going to become adults. And if we don't kind of, I don't want to say get it together, but get some sort of support, it just continues to get worse. So most of you may know this, 96% of the nation has an unmet need for psychiatrists. So there's a huge shortage. There's a lot of data that shows by 2025, it's going to be even worse. There are not enough psychiatrists coming out of residency programs, not enough programs in itself for psychiatric nurse practitioners. In Florida, they're not really allowed to practice at the highest level of their license. There's so many restrictions. So all these things play a part in not being able to meet that need. I think I mentioned wait times. So I cover the Southeast. I think the worst wait time I've heard to date is in South Carolina. There's one psychiatrist and there's a year-long wait to get in to see a psychiatrist. So most of those patients are going to the ED department to get their ongoing care, which drives up costs. And even when you end up in the ED department, usually there's not enough providers even there to see you in a timely fashion. So I'm excited about behavioral health because I think it's an ideal space. I think we talked about telestroke. A lot of behavioral health is interviewing, conversation, collateral history, you know, maybe some labs, some medications, but really a lot of what we do, and when I say we do, behavioral health providers, is collecting information, talking, building rapport. And so, you know, I have 3 kids, my 3-year-old. When I'm off, he knows how to jump on the video and we have a conversation and I can read his face and see his mood. So it just makes sense. I think it has the ability to create a long-term patient relationship. So some of the barriers I used to have, even with going into the home to try to provide mental health, is it becomes taxing for both the provider and the patient. You know, I was going into the home, and I actually had this happen. I drove 50 miles. I didn't check the address correctly before I accepted the case, so it was too late. But 50 miles one way, and you just can't keep up with that. Patients are less likely to be compliant because, again, transportation, do they have gas? Did the car break down? All kind of things. And there are all kind of types of appointments that can be made, individual counseling, group counseling, all type of things. So, insight. Right now, I think you'll see 3 types of telebehavioral health being deployed. So we provide this and other companies do as well. So on demand, you'll find in the hospital EDs, inpatient units, and these are more for crisis. So we actually deploy services within 1 hour if it's a crisis, and 4 hours if it's urgent. And a lot of the EDs are seeing a lot of, I guess, return on investment because they're decreasing that length of stay. They're not getting dinged for that ED boarding. Their ER physicians love it because now they get to, you know, have someone else either consulting or actually taking total control of the case. So they feel more comfortable when patients are leaving that they are safe or they're getting the right type of care. Scheduled services, you'll see FQHCs, community mental health. I'm excited that a lot of primary care offices are now calling with the behavioral health integration, the medical model homes. They now have a resource to be able to kind of punt that specialty off. And so here we provide a psychiatrist that could, you know, range from 8 hours to 40 hours that shows up and actually works in the clinic. I think the important thing is when I'm talking to potential organizations, you know, I always try to stress the point that this is not someone that should just come up on video and kind of go back in the corner after they've seen a patient. I mean, they really have to integrate into your culture, your model, your EMR, treatment team, supervision. They have to really be a part of the team. So some people, you know, that kind of, I think most people are getting it now. Early on, people just really had, I need an answer and I want someone to go away. from my experience being a social worker, it doesn't work very well. We have to collaborate. The primary care needs to know what the psychiatrist is doing, the social worker, everyone has to be involved to make this work. So this is where I'm really excited, direct to consumer. So this is being able to see the consumer where they are in the home. Now most states require, at least in the Southeast, that you have to come to an actual site. So you have to come to the primary care office, or you have to be in the hospital in order to get reimbursement. By the way, Florida doesn't really reimburse at all, so that's a huge barrier as well. But this, I think, is going to be kind of a game changer, especially for ER admissions, because one thing I tell a lot of hospitals is we can come in and we can see people in the ED all day long. But when you discharge them and they go back to the community and it's 28 weeks to get in to see a psychiatrist or 10 weeks to see a psychiatrist, that patient's coming right back. They have no follow-up care, no means to have medication management. And so I think we really have to kind of switch our thinking to stop just dealing with the crisis and really deal with the prevention, keeping people stable. So I actually practice on this model, and I'll talk a little bit about that. So again, I'm going to focus on children here. So all kind of issues can be addressed comfortably through telemedicine, PTSD, abuse, anxiety. I would say the only diagnoses that are, I don't have a lot of comfort with, and I think other clinicians would agree, things like schizophrenia may not be the best median, especially if somebody's not stable. So you do have to kind of think about what makes sense to do via video, what support systems are there. Potential uses, so I mean, we basically do everything via video, and I think this is why telebehavioral health is so prime for telemedicine and televideo, because we can do pretty much everything. So we do psych evaluations, diagnostics, medication management, counseling, parenting classes. So actually, I'll wait on that one. Case management. So just thinking about, I think I mentioned the discharge planning. I've always envisioned being able, I can't tell you how many days I would be trying to get a family member to come up to the hospital, and I got to get off of work, I can't get off work, I only get off to 5, but being able to connect everyone real time, in a visit where it makes sense. So the technology is here, not coming, and I think we really have to kind of wrap our minds around pushing it forward and using it, maxing out the technology. So individual implications, so consistent care, stability and flexibility. And when I think about kids, so when you grow up in foster care, you move around, not everyone, I probably moved around 10 to 15 different times, different communities, different states. And so every time you get in front of a psychiatrist or a therapist, you have to rehash the same story over and over and over. You may not be comfortable with that individual. So with telemedicine, I always envision being able to have a portable behavioral health team. So when I go from one home to another home that may be 30 miles apart, I get to keep my same practitioner. Coming up in foster care, you don't have a lot of stability as far as adults. And so I think this is one way to actually have some sort of stability, to be able to report things. A lot of times you may have some great foster care homes, you may have some not so great. And I've heard people say, well, why wouldn't the kid just say something? Because you don't trust people around you. So if you actually have some sort of trusting figure that has been with you, I think you'll be able to pull out a lot more. So some of the values, I think some other people spoke to this, decreased travel. I think that's beneficial on the clinician's part as well as the consumer. So because I don't have to get out and drive 50 miles to a home now, I'm much more likely to take on visits, do it at night because I don't have to go anywhere. So I think you're able to increase access to providers just by allowing the flexibility. For families, I think it's a lot easier, especially in the case with kids. Normally you're trying to meet those 9 to 5 traditional hours, so you got to take off work, you got to pull your kid out of school, there's a lot of things that you have to do. I'm actually working with a program in Jacksonville to do a school-based telebehavioral program. Georgia has quite a few, and they're seeing some huge benefits to that. I think someone asked a question to compliance. I mean, it's much more easier to be compliant if the session is, most kids are going to school. So they're able to kind of keep up with their care, offer that right in the school system. Portability of service, I kind of talked about that, being able to follow the kid wherever. Another important one, I think, is improve access to a specialist. So I grew up in Atlanta, ended up in Sylvester, Georgia. Anybody ever heard of Sylvester, Georgia? Probably not. But it's rural Georgia in the South. And so I'm from Decatur. I think we had one white kid in my entire school. So when I went to rural Georgia, the only psychiatrist happened to be white, which is not a problem, but that wasn't what I was comfortable with. It was it was a cultural shock to me. But there were no options. And so being able to really align the specialist that works for that kid, whether that be a cultural, language, specialty as far as eating disorder, that is one of the hardest specialists to find. I mean, you usually have to travel hours. So being able to connect the kid, not with just a clinician or the provider that immediately lives in their community, but the provider that best fits their needs. So where can it be used? I think I mentioned hospitals or whatnot, but in the sense of youth, residential group homes, college campuses. I love this one because, when you think about kids going off to college, being able to keep the same clinician. They may go a few states away, a couple hours away. I just think it really promotes compliance among patients because the convenience is there, especially with the generation that's coming up now. My 14-year-old, 8-year-old, they can work iPads and all kind of stuff, and they want what they want now, and they want it how they want it and who they want. So I think the kids that are coming up are very used to this. Jails, I'll go back to jails. So I used to work with, when I first came out of high school, I worked with autistic kids, but I worked in group homes with foster youth and at-risk youth, probably about 10 plus years. And one of the things I used to see quite often is that the kids would have parents that are in jail. And so we don't take kids to on visits to the jail. But not all their parents are necessarily bad people. A lot of it is substance abuse. So being able to connect family sessions when someone's actually in jail, and they're using telemedicine in jails all the time, to be able to connect family sessions where a parent may be in jail, a youth may be in a group home. So the technology allows for you to really get innovative and creative in how you deliver care and connect people. So this is me dreaming. How can behavioral health challenges change behavioral health services? So what if a kid could receive family therapy with their parents or siblings, and not everyone needing to be in the same location? So when I worked in the group homes, one of the issues you have is you may have a family of 5, 2 live in the group home, 1 lives with the family here, 2 lives in the family here. And a lot of times it was very hard for case managers to go pick up everybody, take them to an office, sit in the office for 2-3 hours, everyone's seen, and then come back. But being able to connect everybody and allowing everybody to stay where they are, you're much more likely to have the visits more consistently versus the transportation and the headache. It really is a headache to try to make all of that happen, especially with the caseloads that case managers currently have. So what a behavioral health provider, regardless of where they live, and I think I mentioned that, just being able to keep the same clinician where it makes sense. I mean, sometimes relationships change, but being able to have the same clinician follow you kind of throughout your journey through the system, and even back home when you're reunited, not having to switch up again. I talked about culture, just kind of specialty. Won't drive that home. Case management. I talk a lot in Florida to child welfare, and I'm trying to get them to, I've learned in this that, some people see the benefits from just kind of the human standpoint, and some want to hear about what's going to be my return on investment. So in this, I mean, it has the ability to drive down costs. All the gas that's spent running around, all the time that's spent, being able to really coordinate that care, especially when we can get the EMRs kind of on the same page, where me as the clinician can communicate with the psychiatrist or the mentor or whoever. So some of the challenges, regulations needed to appropriately ensure HIPAA compliance and confidentiality. So one of my biggest fears, and I think I was having a conversation with someone, is everyone wants to do telebehavioral health now, which is great. but some people are just kind of jumping into this and not having an understanding of how to do this. So I've heard people say, oh, I can just Skype. No, you can't just Skype. It needs to be HIPAA compliant. So really educating people on how to do this appropriately so they can protect their licenses and also protect the consumer. Consistency states, so in Florida, we're way behind. We're still trying to figure out the definition of telemedicine. We're kind of moving, but depending on what state you go to, if you go to Georgia, which I cover, they're way out in front. They have the parity bill. Everyone's required to cover this. You can get reimbursement. If you go to South Carolina, it's a bit different. The psychiatrist or clinician has to live in the state. So we really need to kind of push to get on the same page in some sense, set some sort of benchmark, because it really gets confusing even for the clinicians trying to extend themselves on what can I do here, what can I do here. So I really love to see us kind of push in a direction where we have some kind of uniform rules around this. Some of the hurdles, legislative hurdles, are right now, so Insight, we have, I don't know, 200 plus providers, and we have to get all our physicians, clinicians licensed in every single state that they practice, which is a huge headache for medical affairs, not only for medical affairs, but you have to keep up with all these licenses. The good thing is that we have the interstate compact is really kind of gaining some steam. I'm not sure how many states we're up to now, but the goal of that is to provide some sort of standard. If you're licensed here in this state and they're part of that compact, then they're going to fast track those applications so you don't have to keep going through the redundancy of each state. So that really holds us back when we go into a health system and we're trying to get up and running. We have the psychiatrists ready to go, but we have to go through the licensing for the state. And then once we do that, we have to go through the Medicaid. And then once we do that, we have to go through the credentialing of the hospital. And before you know it, it's 6 months before we can actually roll out. Meanwhile, people are not getting the care that they need. I think one of the bigger issues is reimbursement. Like I said, some states have parity, others don't. Again, in Florida, the Medicaid guideline kind of wrote it as you may cover. So we have a ton of managed cares in Florida that have decided not to. We have a few that do. But I think until people can start getting reimbursed for this, it's going to be a huge barrier to increasing the number of clinicians that are actually practicing. So how do we get there? It's always baffled me. I love when I love coming to conferences like this. I love it when it's, like-minded people. However, I think we could benefit from more directly targeting consumers, to really be a voice on being able to access telemedicine. I'm always surprised when I talk to consumers that they have no clue. They really never heard of it, don't understand it. So I think we could really benefit from educating consumers, not only educating them, but encouraging them to advocate as well. Creating telebehavioral health systems. So Mayo Clinic, that's super exciting that you guys are kind of going down that road, but seeing more telemedicine on a broader level. So usually when I'm talking to a hospital, everyone seems so siloed. So I'm talking to the hospital and I'm trying to encourage them to think about putting it in their network of primary care offices. Well, that's not really our concern right now. Our concern is the ED. And I'm saying you can't really separate them out. You have to be concerned with the primary care because that's why they're coming to the ED. Mobile crisis. So it's encouraging to see some systems are really becoming innovative. But if you're part of a system, if you can get them to think outside the box and not just about correcting their little piece of the problem. Increase the number of providers. So I think providers are coming along. I don't know with psychiatrists if it seems, I don't know if it's a territory thing. I get some psychiatrists that they're on it and some just want no parts of it. I get questions like, is this going to take over face-to-face or is this going to take all my patients? And it's impossible. I told one doctor, you'd rather have a 6-month wait list or a 2-month wait list. I mean, your wait list is not going to go away. Patients all of a sudden are not just going to, we're not going to fix this problem overnight. So getting more providers more comfortable with telepsychiatry or telebehavioral health, clinicians as well. And then advocate on the legislative level. So we actually had a victory in Florida last week where the medical board finally approved for controlled substances to be prescribed for psychiatric disorders. So I actually had the opportunity to talk to one of the physicians on the medical board. I'm sure this didn't do it, but hopefully it helped. So what I was explaining to him, in Florida, we had the reputation of having the pill mills. And so the reason why they didn't want the prescribing is because they thought everyone would go crazy with the chronic pain or whatnot. But what was happening is in the outpatient setting, a lot of kids with ADHD or things of that nature need Adderall, they need stimulants, and you couldn't prescribe those. So they were being affected in a negative way. So finally they came around and now you can prescribe that, which is a huge win. But really getting in front of your legislators and letting them know how important this is. I found that mental health for whatever reason, it just seems to be low on the totem pole. So I think we just got to have more of a voice around it. So I was going to give this case study, but so I think in January, and this is why this is so important, and this is my life work. This is what I'll do. So I got a call, I think beginning of January, about 1 o'clock in the morning, from a friend of my sister's who also came up through the foster care system. And this friend was telling me my sister was in jail and that the kids were removed. And so long story short, now my 2 nephews are in the foster care system. And so in my family, here's another generation where mental illness, and she doesn't have a mental illness, but I would definitely say her mental wellness wasn't addressed. So now we have another generation that has to kind of go through that, where I feel like if we can really kind of get mental wellness, mental health under control, where my sister, maybe gotten some resources to be able to prevent that. But now again, my nephews are going to be part of that, those statistics that I showed you, and now I'm going to have to kind of fight to make sure they get the mental health services they need. And so it hits home again to think that they may have to wait 28 weeks to get some sort of counseling, hopefully no medications, but to get the appropriate care that they need. So I have a Twitter, I don't use it often, but you can follow me there. I have a website, Underdog Dreams. So anytime I speak to the kids, that's just kind of my motto. There's a lot of skills that we've picked up from going through those situations, and we just got to dream big. So I appreciate everyone's time.